So, welcome everybody to our afternoon, the first of our afternoon session presentations. This is focused on tackling alcohol and smoking harm. And so we're focusing on older age groups in this session. If you are online, please do remember to submit any questions you have for the panel on Slido for the Q&A after the presentations. I'm delighted to introduce Professor Jamie Brown, Director of the UCL Tobacco and Alcohol Research Group at the UCL Institute of Epidemiology and Health Care, who will chair this afternoon's session. Jamie.
Thanks very much, Graham. Welcome, everyone. Really delighted to chair today's session on tackling alcohol and smoking harm. Smoking and alcohol, as I'm sure everyone here knows, remain the two largest preventable causes of premature ill health and mortality, and they continue to drive stark inequalities across populations and across the life course. It's actually a particularly well-timed session because I'm reliably informed that the new tobacco and vapes bill has either just received or is just about to finally receive royal assent, and so will pass into law today. And as some of you will know, that bill includes a range of world-leading legislation, with the centrepiece being the landmark smoke-free generation policy, which will mean people born after 2008 will never be able to be legally sold tobacco in the UK. So a huge moment. One of the strengths of research in this area is the ability to track behaviour at the population level over time, evaluate what impact policies, services and wider and social change have on the real world. And today's session will reflect that strength, bringing together work across disciplines spanning behavioural research, policy evaluation, population surveillance, life course perspectives and creative community-based approaches to harm reduction. So really looking forward to the session and the discussion. Let's begin with our first presentation. Delighted to welcome Professor Linda Bauld, who is the Bruce and John Usher Chair in Public Health and co-head of the Centre for Population Health Sciences in the Usher Institute of the University of Edinburgh and Chief Social Policy Advisor to the Scottish Government. Linda has been a leading voice in public health for, I think, around 30 years and a giant of tobacco control in particular. And I've worked on joint research collaborations dating back to 2010 when I first started working in the field. So I'm particularly delighted to welcome Linda and thank her for joining us all the way from Edinburgh. Thanks very much, Linda.
Thanks, Jamie. Delighted to be here, and thank you very much to Graham and colleagues for the invitation. So I'm going to start this session talking about smoking in pregnancy, which is a very important and challenging area that has multiple health harms for the mum and the baby. It's a leading cause of maternal and neonatal mortality, and we've made huge progress in this area, and that's what I'm going to talk about because I think it provides a model for other public health topics and other causes of non-communicable diseases that we need to make further progress on, including the earlier session that you heard today. So I'm just going to talk a little bit about the changes over time in this issue, why we've seen progress, the importance of multi-agency collaborations, highlight some of the key studies, and then next steps, which is all fairly challenging in 10 minutes, but I think we can do it. So these are the shifts over time. You can see this is smoking at the time of delivery. Like many population health measures, we measure it in different ways in different places. In England, it's measured when the baby is born or towards the end of pregnancy. So you need to think, these are women, if they are still smoking at that time, that late in the pregnancy, they have really struggled to quit early on. And most women who stop smoking do that when they discover they're pregnant or preconception if they're planning a pregnancy or in early pregnancy. So these are highly nicotine dependent women. But you can see those shifts over time, and we've seen some very dramatic falls in recent years. So going down, as I say, from 15% in 2006-07 And the third quarter results for the latest data are that we're down to 4%. So really important progress, and I'll explain why. But more significantly, we could completely eliminate this issue. And I think we're on track to do that. Now, Jamie mentioned over the last 30 years of working on nicotine and tobacco research, if you'd asked me when I was a PhD student and postdoc, did I think we'd eliminate combustible tobacco smoking from society, I would have said absolutely not. But now I actually think we can, because we've got lots of other products. Humans have been using nicotine for millennia. That's not necessarily going to end, but we can get rid of the most harmful use. So the modeling here suggests that by 2031, we'll have near zero smoking at the time of delivery rates. So why have we seen these shifts? What's contributed to these reductions? So I just want to take a few minutes to go through the key components. The first thing is they reflect changes in the population prevalence of smoking, and I'll show you that particularly for young people. If you think about that preconception period, our future parents, young people. But that's not the whole story. As you can see, those more rapid declines recently, and that is due to system change that's been a key factor. And this includes embedding a comprehensive approach to stopping smoking during pregnancy as part of the Saving Babies' Lives care bundle that I'll briefly explain through the NHS long-term plan. So just to start with the population level drivers, these are data that relate to the ASH YouGov survey that's been running for many years, and you're looking here at 11 to 15-year-old smoking. So you can see through time, essentially legislation. So changing the environment around the behavior and the determinants of that behavior, and also addressing supply and demand. So things like illicit tobacco, front-to-pack warnings, dealing with advertising, right through to standardized packaging, which is removing the last form of tobacco marketing, putting tobacco behind the point of sale, and then also dealing with, of course, the price, which is a main driver, and the environment around smoke-free. So you can see we've got really low rates of smoking now in teenagers, and these, as I say, are the future parents. But there are other drivers as well. So I'm going to start at the bottom of this, which is the Nuffield Council for Bioethics model. You'll be familiar with that. And that's adapted here on this image by the King's Fund. So if we start at the bottom, effectively in behavior change, the option is to do nothing. But you can then provide information, and that's what we did for years with pregnant women and parents and families, telling them about the harms of smoking and encouraging women to change their behavior, including encouraging their partners to quit. Not very effective, but important. You can also enable choice by directly giving support. And this is what the NHS long-term plan has really achieved a step change in. So that plan and the Saving Babies Care bundle, which is essentially a set of clinical recommendations for reducing perinatal mortality, required to be implemented by the NHS, put in place in 2016, but the funding dedicated to tobacco dependency treatment services for pregnant women came in 2019. And we think that's what has the main driver has been of those reductions recently. And that means that all women receive a carbon monoxide breath test, and then they have to opt out of receiving tobacco treatment, available across all parts of the country. And then, of course, guiding choice through the default policy, which is that direct referral that I mentioned. But then you get up in the bioethics hierarchy to thinking about incentives. And since the Saving Babies' Lives care bundle was introduced, we also have a world-first national smoking in pregnancy incentive scheme, where women are provided with vouchers alongside stop smoking support to help them to quit. And I did some of the early trials on that, and it's a really effective, in fact, it's the most effective approach to smoking cessation in pregnancy. Of course, the other things that we do, which are at the population level, making the product more expensive, making smoking in communities and outdoors and in public places denormalized. And we know that the smoking ban, now 20 years old in Scotland, soon in England, not only did we see the ban in public places, but actually fewer people smoking in the home. And then doing things, as Jamie says, that we're now really turbocharging with the tobacco and vapes bill, of having that age of sale for everybody born after 2009 won't be able to be legally sold cigarettes. So big changes, and that's what we need to do, and I'm sure you heard that in the earlier sessions, for other public health challenges. Provide services, information, and support, but change the environment around the determinants of the behavior. And the key thing for me has been that in 2011, the then Minister for Public Health set a challenge to the public health community and the maternity community to come together to address smoking and pregnancy. And that's why it's called the Challenge Group. And I've co-chaired that with the Chief Executive of the baby charity SANS since 2012. And it's a fantastic group. It meets regularly, and it's making sure that in all parts of the country we're doing the communication, but we're also embedding the service change. And I think when you speak with a single voice, whether it's advocacy or for practice and policy, you're much more likely to be successful. And that group will continue to meet. Very briefly, and then I'll conclude, is to highlight the important work that my colleagues have done. Because in terms of this type of system change, it's evidence-based because we had research funders who funded the work that effectively provided the evidence that we have today. So we start out with that routine CO monitoring. We did a study that found that the level we use, this sounds technical, but it's important, for the general population was too high in pregnancy because of the way that the body changes in pregnancy and how women metabolize nicotine. So a lower level was needed. We then had important trials around nicotine replacement therapy, which can be prescribed in pregnancy, and showing that this was safe for babies up to 2 years, and that we probably needed higher doses, actually, which is work that's ongoing. And then, as I mentioned before, we actually started the studies on financial incentives back in 2006, asking women and professionals what they thought. And we then had that MRC pathway of moving from feasibility to pilot to multi-center trial, and then real-world phase 4 studies in Greater Manchester and elsewhere, evidence in the Cochrane Review, a change to NICE guidance, and then a national program. But it took 20 years. So if we could accelerate these stages of change, it'd be better. And then in terms of advising on vaping, still controversial, but we've done, Peter Hayek and colleagues have done the only randomized control trial in the world on this, and there is a swap to stop program which provides free vapes, but we do need more research on vaping and pregnancy. And without the challenge group taking our evidence and my colleagues' evidence and engaging with policy and practice to make the case for change, I don't think the research would have had the impact that it has had. Finally, of course, we still have substantial ongoing challenges. If you go to some parts of the country, smoking is still common and embedded in communities. We have promising findings on relapse prevention, so we know up to 60-70% of women, if they're heavily nicotine dependent, will still relapse postpartum. We need better interventions there. As I say, we need more research on vaping and pregnancy. And the problem is when you tell a success story, which this one is, policymakers, practitioners maybe lose interest and the money goes away. And until you've eliminated the issue and the challenge, we have to keep advocating for the fact that more needs to be done. So I hope that was an interesting example. Our research consortium, which Jamie is part of, Behavioural Research UK, you can find out more about our studies here. Thank you very much.
Thanks very much, Linda. Inspiring presentation, lots of key lessons there, I think. So I'm sure you've got lots of questions for Linda, but the plan is that we're going to take all questions at the end after we've heard from all speakers together. So please hold those questions for the end. So next, I'd like to welcome and thank Professor Sarah Jackson, who works with me at our UCL Tobacco and Alcohol Research Group. And very topically, Sarah's going to be talking on recent trends in smoking and vaping in England. Over to you, Sarah. Thank you.
The mic may take a second to switch on. Here we go. Hi everyone, nice to be here. As Jamie said, I'm going to take you through some of our recent work on trends in smoking and vaping in England. So for decades, nicotine consumption was almost entirely through tobacco smoking and primarily cigarettes. And this meant that the messaging was really simple and smoking rates came down, as Linda pointed out, quite quickly and steadily, in large part due to progressive tobacco control measures. But the emergence and rapid uptake of e-cigarettes has introduced a new dimension to population-level patterns of nicotine consumption. And with it, there's been a shift in focus away from smoking and onto vaping. And in particular, there's been a lot of concern in recent years about rapid uptake of vaping among young people. So today I'm going to take you through some of the latest evidence on smoking and vaping, with a focus on recent trends in adults in England. So the data I'm going to be presenting today come from the Smoking Toolkit study, which is funded primarily by Cancer Research UK and coordinated by our team at UCL. The Toolkit is a national surveillance programme, and it provides real-time insight into smoking and nicotine use in Great Britain. Since 2006, we've conducted monthly cross-sectional household surveys in England, and with recent investment from the Spectrum Consortium and Behavioural Research UK, the study expanded to cover Wales and Scotland from 2020 onwards. To date, we've collected data from over 440,000 people, and this allows us to track trends in smoking, vaping and quitting, which we report on our website here, which is updated monthly. But the data also enable us to undertake rapid evaluation of the impact of different policies and to apply advanced modelling to understand behaviour change at population and individual levels. And because the data are collected monthly, we can detect changes pretty much as they're happening. So for today's talk, I'm going to focus primarily on data from England, as this is where we've got the longer term trend data available. But I'll also show you some studies we've done in Great Britain as well. So first, I'll start with smoking. So we'll start with some good news. The prevalence of daily cigarette smoking has declined by more than half since 2007, albeit with a bit of a slowing in the rate of decline since COVID struck in 2020. And we currently estimate that it's at a record low of around 10% of adults in England, although it does remain much higher in disadvantaged groups. The less good news is that non-daily cigarette smoking has been growing since the onset of the pandemic. So the top line here is the overall prevalence of daily and non-daily combined, which, as you can see, is declined by less than the prevalence in daily cigarette smoking. So the gap between overall prevalence and just daily smoking has grown since 2020. So to put it another way, there's a growing proportion of smokers who don't smoke every day, to the extent that we estimate that now around a quarter of all smoking is non-daily. Now, you might ask, well, does non-daily smoking matter? If people aren't doing it every day, do we need to be so worried about it? Well, we estimate that non-daily smokers in England smoke just over a pack of 20 cigarettes a week. And while this will cause less harm than the average 4.5 packs a week consumed by daily smokers, it's definitely not trivial, and some of the risks of smoking are similar whether you're smoking daily or non-daily, particular cardiovascular risks. Another trend we've been seeing is that non-cigarette smoking has also increased in recent years. So non-cigarette smoking includes things like cigars, cigarillos, shisha, and things like that, but not non-combustible products and not alternative nicotine products like e-cigarettes. So here you can see that non-cigarette smoking was very rare for most of the period that we've been monitoring it, to the extent that the two lines here are pretty much the same up to about 2020. But since 2020 onwards, there's been a divergence in the prevalence of any tobacco smoking and cigarette smoking. And this means that a growing proportion of adults who smoke tobacco don't actually smoke cigarettes at all, but are using another form of combustible tobacco product. So if we look at this as a proportion of all tobacco smoking, we estimate that around 1 in 10 people who smoke exclusively use non-cigarette products. And there'll also be others within these blue bars here who smoke both cigarettes and non-cigarette tobacco. So overall, what this tells us is there's been increases in both non-daily and non-cigarette tobacco smoking. And if we look at this broken down by age, we can see that these shifts have been particularly pronounced among younger adults. So here you can see that among adults who smoke, there's been a particularly sharp decline in the daily cigarette smoking prevalence. So the proportion of 18 to 24-year-olds who smoke cigarettes daily has fallen dramatically. And that's been offset largely by an increase in non-daily smoking, but also partly by an increase in this non-cigarette tobacco smoking. So by 2023, fewer than half of young adults who smoke reported daily cigarette smoking. By comparison, older age groups have maintained much more traditional smoking patterns, with over 70% of those aged 45 and older still smoking daily. Now, these changes in smoking patterns have happened in the context of changes in vaping. Up until 2021, vaping prevalence in England had been relatively stable for a number of years, and it was rare for someone to vape if they hadn't ever regularly smoked. So vaping was concentrated among people with a history of smoking. But then disposable vapes entered the market in 2021. So these were cheap, colourful, easy to use and very attractive to young people, and we saw them rapidly become popular among younger age groups. And this led to a sharp increase in vaping prevalence, in sustained vaping, and including among people without a history of regular smoking. The increase was concentrated in younger age groups, with the prevalence of sustained vaping rising to the highest levels among 18 to 25-year-olds. And by April 2024, around 1 in 5 18-year-olds who had never regularly smoked was now vaping. And this rapid uptake of vaping in never smokers caused the long-term decline in nicotine use to reverse. Among 18 to 24-year-olds here, you can see the proportion who've smoked or vaped, which is shown in the black line, was falling steadily up to 2021 and pretty much mirroring the decline in smoking. But from 2021 onwards, as vaping rose sharply, we saw this trend reverse. A similar pattern was also seen in older age groups, but the magnitude of the increases in vaping and therefore in overall nicotine use was smaller with increasing age. However, we also saw that recent declines in smoking, which you can see in yellow here, have also been the most pronounced in the age groups with the greatest uptake of vaping. In fact, we see that under 25s are now more likely to vape than smoke. By contrast, over the same period, we actually saw a slight increase in smoking in the oldest age group. Now, this makes things a bit complicated, and it suggests that vaping regulation needs to be proportionate and balance the risk that excessive restrictions on vaping may be associated with increases in cigarette smoking. However, the rising prevalence of youth vaping did raise concerns and contributed to policy discussions about banning disposable vapes. And in January 2024, the government announced its plans to do just that, citing two aims, which were to protect the environment and to reduce youth vaping. And what's striking is that our data show that behaviour began to change almost immediately before the ban was even implemented. When we looked at the devices that people were using, we saw a rapid shift away from use of disposable vapes towards using these refillable, rechargeable devices. Now, this likely happened for two reasons. News of the ban attracted widespread media coverage, with many reporting on the negative environmental consequences of disposable vapes. But importantly, the market adapted very quickly, and within months of the announcement of the impending ban, companies that sold the most popular disposable products had re-released new rechargeable versions of these popular devices. As you can see here, they're visually almost identical, and they were sold at a very similar upfront price. Now, this created some potential unintended effects. So first, because the very similar products remained available, the impact on youth vaping was likely quite limited. Young people weren't using disposable vapes because they could throw them away. They were using them for all the other features that still remained in the new models. And secondly, for those who were using these products, they offered a cheaper way to vape in the long run, because now you didn't need to buy a whole new device every time you ran out. When we looked at how much people were spending on vaping, we saw that after the disposable ban was announced and these new rechargeable products started to come to market, average expenditure levelled off and then began to decline, particularly among the younger vapers. So the ban seemed to unintentionally make it cheaper for young people to vape. We've recently been starting to analyse impacts of the announcement and implementation of the ban on vaping and smoking prevalence. And early data, so this is work led by Harry, suggests that vaping prevalence among young adults has now plateaued. So this suggests that the policy may have helped to curb this rapid rise in vaping among young people, as it intended to do. However, we also see some possible unintended effects on smoking in this age group. Before the ban, smoking prevalence was decreasing, but after the ban was announced, this trend reversed and smoking rates began to increase, at least in the short term. The downward trend appeared to resume after the ban was implemented, but prevalence does still remain slightly higher than we might have expected had the pre-ban trend continued. So while disposables may have been a key driver of sort of the recent surge in vaping among young people, it's clear that banning them hasn't been a straightforward solution to the problem. And this suggests that we need additional policies that reduce the appeal of these products to young people, while also avoiding unintended consequences, particularly the risk that these new restrictions may push them to smoke instead. As Jamie mentioned, we've got a number of new policies set to be introduced very soon, possibly as I speak, under the Tobacco and Vapes Bill, which, we believe has just received royal assent. And this includes, as Jamie mentioned, the landmark smoke-free generation policy to progressively phase out the legal sale of tobacco. Minimum age of sale restrictions extended to all nicotine products. I haven't had time today to talk about nicotine pouches, but they're another non-combustible product that currently have no minimum age of sale. And further restrictions on marketing and sales. And the bill will also give the government powers to introduce further restrictions under secondary legislation, including extending smoke-free legislation, restrictions on flavours, product design, packaging and point-of-sale displays, and retail licensing. So we'll be continuing to collect data to understand what happens to patterns of smoking and nicotine use, and sort of what it means for the future of this field going forward. I'm going to leave it there, but I'll finish by leaving up some acknowledgements, including a link to find out more about the Smoking Toolkit study, which produced all of the data that I've presented today. Thanks.
Thanks very much, Sarah. Another brilliant presentation, lots of nuance presented very clearly, I think. So I'd now like to introduce our third speaker, Dr. Ranjita Dhital, who is an Associate Professor in Interdisciplinary Health Studies in the UCL Arts and Sciences Department. And Ranjita is going to talk to us about creative transdisciplinary alcohol research in Nepal. Thank you.
Right, well, thank you very much. I'm so pleased to be here and, really it's nice to be part of this community. And so I'm going to be taking you to Nepal. And before I start, has anybody been to Nepal on holiday or on work? And okay, quite a few people, very, very good. And I'm originally from Nepal, and so I've been doing a lot of research in the UK to do with alcohol use, and I'm now kind of looking at looking at sort of global health, but from a very interdisciplinary, transdisciplinary approach. So that'll give you an overview of the work. And it's very surprising, sort of alcohol use and the culture of alcohol is fairly absent in research, in published work, scholarly work, particularly relating to, in public health. There's a lot of work in anthropology about practices and cultures, but how it links to health, how we can prevent harm, what kind of training, what services need to be kind of produced, is absent. And also the culture of drinking, how it fits into people's lives, how do people drink. So here's an image from a sensory ethnography work we did in Nepal, and this was near Kathmandu in an area called Tattan. Those of you who've been to Nepal may have been there. And these are some photographs of my research team. And alcohol, about 70% is produced locally by individuals in people's homes or within communities from grain, and is either fermented, so about 5% sort of ethanol concentration to about 40%. So that's the same as whiskey, really, really strong, but produced locally. So the production of alcohol and the consumption and how it fits into cultures is actually really kind of not known and not a really big discourse in this area. And a lot of sort of work that is known and research that's been developed is sort of based on a Western pattern of drinking. And you can see here the green sort of block at the bottom. So in the countries like the UK, about 75% are low-risk drinkers or don't drink. And this middle group, this harmful, hazardous group, where there's been a most extensive amount of research that involves psychosocial intervention, motivational type conversations to reduce drinking, which have been found to be quite effective, to lower the drinking to low risk level, and to prevent somebody from increasing their drinking so they become dependent drinkers. So that's the kind of pattern we have, and a lot of work has been sort of focused around this type of pattern. But the pattern of drinking in Nepal is a little bit like this. This is not based on, we don't have a lot of really, really kind of robust data, but from what we were able to do and what we were able to gather. And the green block is actually non-drinkers. A lot of people don't drink, and it's due to kind of women don't drink, cultural, religious reasons. But you can see this middle group, 16% are harmful drinkers, and a really high 12% are almost dependent drinkers. So it shows that in Nepal and other countries like Nepal, people either don't drink at all, or when they drink at a really high dangerous levels. So therefore the way we conduct research, what knowledge we produce, services and support really needs to be sensitive and very fully aware of this type of pattern, and to understand a bit more about the ways of the behaviors of drinking and associated with culture. So with my work, I'm proposing a transdisciplinary approach to reducing alcohol harm. And with that, I mean, it's not just bringing disciplines together and integrating it to find new knowledge, but we are working directly with communities. And our communities aren't participants or volunteers, they are co-researchers. So we are working with communities whose experiences are a very important form of expertise and knowledge. So the work that I'm doing is exploring processes and finding out how could we do this. So my work is currently very methodological and very scoping of the methods that we can use. So, about less than 20% of research from so-called low middle income countries, from the global majority countries, very, very little is produced. And, it's surprising when majority of the harm, premature deaths, and illnesses are experienced from those from the low middle income countries. So, and also is aggravated by NCDs, particularly the risk factor alcohol. So these are the facts, and what is happening in reality doesn't really translate into what goes on in terms of public health interventions and programs and funding and support for reducing this kind of really the deaths and illnesses that are avoidable and preventable. So, there's a kind of a bleak view on this, but I think also looking at it differently, the work that I've been doing in Nepal when I'm there, I'm finding that the community knowledge, cultural practices are very rich and diverse. And I'm very interested in optimizing those practices and how they can be transformed into public health interventions. The way, our epistemology, the way we know things, what we know, how we know things. So that's why taking this very transdisciplinary approach is what I'm very interested in. So really we need to look at the way we do global health research, moving beyond that very deficit model, very extractive model, and at times very exploitative. We really look at Western countries and nations going over to global majority countries to take data, analyze, and coming up with recommendations. We really need to look at that and question that. And there's been a lot of kind of discourse around this. So I should mention the image that I have here is from one of my research projects where we did an alcohol festival, not a festival for drinking, but it was about a festival for sharing the findings. So there are many festivals in Nepal. So instead of having a conference to disseminate the findings, we did a festival. And here is Shubha, who's one of the lead people from our women's group, our co-researcher. And she was sharing the work that we did. And we worked with Nepali artists to communicate the findings in the place that she is based. So I just wanted to show you an example. And that was one of the flyers and posters we had for this festival, for the alcohol co-design community engagement study. And the flyer is interesting because it's quite contemporary in design. It's by a contemporary Nepali artist. So in that festival, we were introducing new ideas from the younger people, as well as more traditional people who were coming together and planning this activity. And there was a really interesting sort of knowledge exchange. And these are some of the main findings from that. So yes, there's diverse experiences of alcohol. Stigma is very prevalent. But communities have resources and cultural assets that we could really optimize. And yes, support is needed from external sources, but it needs to be very carefully considered. So just some lovely images of some of the festival activities. And it was very, very interesting seeing how people engaged, what they did, and how we kind of managed to do this. So it kind of, an alcohol festival is, thank you, it's is interesting, isn't it, as a public health kind of way of sharing knowledge. So, moving on from that, I'm building this discourse. So beyond alcohol, I'm looking at creative health. So it's creative public health. And we did an exhibition at Art Gallery in Kathmandu to kind of discuss this even further, and invited people from my study over to the art gallery who'd never been to an art gallery before. And it was disrupting these spaces, and the women who were very shy at the beginning when I'd met them 3 years ago, very, very different when they were really working really well with the artists and sharing lots of ideas. So I will just end with, when you're doing this type of community engagement work, the outputs are very kind of diverse, and creating a special issue, engaging with kind of global scholars around the world and practitioners, sharing stories and exchanging knowledge, really important. And different types of outputs, and it's not just publications in books and chapters, which some examples here, but also our community, our co-researchers, the artwork that they produce, to have an exhibition, and blogs that they've written to share their experiences and stories. So the purpose of this here, that this would really help create a really good grounding for future research and future practice. So this is part of the work we're doing, and it's still ongoing. I think the slides will be available for you to look at if you're interested. We've got a Creative Research Methods Conference. So this scholarship is really taking hold, and it's an exciting field. So thank you very much. Great.
Thanks very much, Ranjita. Fascinating presentation, such valuable work, really interesting perspectives. I'd now like to introduce and thank our fourth and final speaker, Dr. Harry Tattan-Birch, who is a senior research fellow and statistician, who also works with me and Sarah at our UCL Tobacco and Alcohol Research Group. So apologies for our slight over-representation, but you can probably understand why. But I just want to mention Harry has been selected to speak as a winner of the Early Career Researcher Abstract Competition. So very well done, Harry. And over to you to talk about cigarette dependence being greatest in smokers who start young. Thanks.
Thanks, Jamie. And I realised that the title of my talk is somewhat of a spoiler. So if you just want to go to the loo now, then feel free. But yeah, it's a much more focused talk than the others on a study we did looking at how cigarette dependence changes based on the age at which someone starts smoking. So as some background, most smokers start smoking, they have their first puff of a cigarette during adolescence or childhood, with 95% starting before the age of 25. And of these people who try a cigarette, many go on to become dependent on smoking, with 2/3 going on to smoke daily at least at some point in their lives. And this is why it's a big public health priority to prevent smoking at young ages. And one of the ways that governments do this is through age of sale restrictions, where you can only buy tobacco, or you can only legally be sold tobacco if you're of a certain age. So, for instance, it used to be 16 in the UK and it went to 18 in 2007. In the US, they've had a Tobacco 21 movement where they've increased the age to 21. And as we've discussed already today, the smoke-free generation policy is coming in the UK, starting January 2027, which will mean that anyone born after 2008 will never legally be able to buy cigarettes or be sold cigarettes, which is essentially like increasing the age of sale every year such that they can never reach the age at which they would be able to buy them. And one of the challenges to policies of increasing the age of sale is that they the benefits might be limited if it simply delays when people start smoking rather than preventing it entirely. Because we know that the harms of smoking come from decades of use, and if someone stops at a young age, it tends to not have substantial negative health effects. And an example given would be Japan, which for over 100 years have had an age of sale of 20, yet they have very high smoking rates in adults. They just start at a later age. But that critique misses that later uptake might still be beneficial for one reason, and that's because delaying smoking might reduce how dependent someone is on smoking throughout the rest of their lives. And that's exactly what we wanted to answer. The research question was, do smokers who start at a younger age have higher markers of cigarettes dependence into adulthood? And to answer this, we used data from the Health Survey for England, which is an amazing data source if anyone who runs it is here. And we use over 2 decades of data where it's collected yearly and participants are interviewed and then invited for a nurse visit a few days later where they give a saliva sample. And that's the thing we used here for one of our markers of dependence. And we included adults aged 25 and up if they currently smoked cigarettes. Obviously, you can't measure cigarette dependence as someone who doesn't smoke. And we chose the age of 25 because this is the age at which the vast majority of people have had a chance to start smoking. And then the sample size was 26,000 interviewed, and fewer provided a saliva sample of around 14,000. The key exposure was retrospective reporting of how old someone was when they started smoking. Very simple. How old were you when you started to smoke cigarettes? And they could provide any age in years. And we analysed it both each year individually, but then also we fit a model through each of the years. The key outcomes were 3 different markers of cigarette dependence. The first was an objective marker, saliva cotinine, which tells you how much nicotine someone's taken in the past few days. And then the other 2 were from the interviews. They were self-reported measures of the average cigarettes, number of cigarettes someone smokes every day, and whether someone smokes soon after waking, so within 15 minutes after waking up. And that's a really useful measure and has been widely validated because it essentially tells you the ability for someone to restrain from the cravings to smoke after a period of abstinence when they were asleep. The analysis used log linear and log binomial regressions before and after covariate adjustment, and the core estimand, the thing we wanted to estimate was the relative percentage change in dependence for every 3-year delay in starting smoking. And here are the results. On the horizontal axis, you can see the age of starting smoking, and then on the vertical axis, you have the 3 different measures of cigarette dependence. And what you can see is a clear negative trend where the older someone starts, the lower their level of dependence. So it's a 12% decline in saliva cotinine in cigarettes per day for every 3-year delay in starting smoking, and a 21% decline in the probability that someone smokes within 15 minutes of waking up. But you might ask, is this really about the age of starting, or could it be other differences between people that are leading to these associations? So for instance, people who, we know that people who are from more disadvantaged backgrounds have higher levels of dependence in adulthood, and maybe they also are likely to start at a younger age because of the social environment that they're in. So we attempted to account for that through covariate adjustment for a range of factors, including current age, sex, housing tenure, social grade, education, and survey year. We would have liked to adjust for much more and for stuff measured at a younger age, but this was what was available. But what we saw was, you might not have even noticed, but the graph has actually changed, and it led to a very slight attenuation, weakening of the association. So instead of 12%, it's 10% or 11%. Instead of 21% for every 3-year delay, it's 18. So the associations essentially were robust to the adjustment for this. So to summarize, in England, people who start smoking earlier in life become more dependent than those who start later. And the effect sizes are really large. Just to put it in another way, someone who starts age 10 has double the nicotine intake and smokes double the cigarettes per day than you would have expected if they had started at age 24. And the associations were also found across all birth cohorts in some results I didn't show here, from 1940 all the way up to 1990. And what might explain this link between dependence and age of starting? The first explanation is the idea of a sensitive period, that maybe smoking earlier in the process of neurological and psychosocial development might make someone especially susceptible to become dependent. And there's some animal studies across a range of addictive behaviours that suggest that. The second is simply that people who started younger have been smoking for longer, leading to more prolonged reinforcement. And the third explanation is maybe it's all just confounding. The association might not be causal at all. There's a risk of selection and collider bias because we're only looking at people who are still smoking by the time of the survey, although that would actually lead to our associations looking weaker than they are in reality, and also unmeasured confounding. So what does this mean for policy? Well, policies that aim to discourage youth smoking, including age of sale restrictions, may have two benefits. They might reduce initiation entirely, so the number of people who would start smoking by age 25. But even if they had minimal effects on initiation and simply just delaying the time at which people start, they might still have a benefit through reducing the level of dependence in the smoking population. And if you have people who are less dependent, then they'll find it easier to quit later in life. And that's actually what I want to look at next in using some longitudinal data. Of course, that relies on these results being causal. And however, we always need to evaluate policies directly. So when the smoke-free generation policy comes in, it will be the first time in the world anyone's done this. So it's really important that we track what effects this has, both intentional and unintentional. And our team will hopefully be doing this very soon, so keep an eye out. And if you'd like to find out more or email me any questions, then you can contact me there, and the preprint is through that QR code. Thank you.
Thanks very much, Harry. Another excellent presentation. Yes, please. I'd like to invite all our speakers back onto stage now for our Q&A session. Just while they're joining me on stage, can I ask people with us in the audience today to raise your hand to ask any questions you might have, and then just wait for a roving mic to arrive. And before asking your question, can I ask that you just briefly introduce yourself as well, so we all know who you are. I'd also like to encourage our online audience to submit questions as well. To do so, I believe there's a Slido link in the chat, and a member of the team here will read out any questions from the online audience. So please, any questions from the audience can either be quite specific or more general ones. I think we've got a few on this side of the room. Yeah.
Hi, really interesting, thanks. I'm Helen Rowe. I'm author of Eliminating Poverty in Britain, and I'm writing a book on the biology of poverty. This is a question for Dr. Ranjita Dhital. I know nothing about Nepal, so it was really interesting. But what I'm curious about is if 87% of women don't drink at all, then the harmful and dependent drinkers are most likely to be men. Is drinking associated with a lack of painkiller access? And also, what's the kind of mental health support for people in Nepal as well? What is the causes of that, or is that part of your research?
Thank you very much. I hope you can all hear me, because I think there were some problems with the mic earlier, but thank you for that question. Like drinking, as I mentioned in my first slide, there's such a complex and a range of reasons why people drink. And in countries like Nepal, where it has cultural and religious kind of connections, from the birth and ceremonies of a birth of a child, alcohol is there. And these are kind of cultures from thousands of years. And so throughout the life course, alcohol is used in lots of various different ways. But over time, we're kind of noticing a really kind of dangerous, this dependent, really, really heavy drinking. And the social drinking that we have in the West, where you drink and you stop, or you drink with friends and then you go home. The very, very heavy drinkers, they drink when everything in the house is gone, because the drinking is made in the home. So there is no stopping until the alcohol is finished. And so we're noticing that and also in terms of support, there's only one national mental health hospital in the whole of Nepal, in Kathmandu, very poorly funded, and that's in Tattan, where my research took place. And a lot of services are private, you have to pay, there is some subsidies, but the training is very punitive type training and skills that people have. That's why there's a lot of stigma around this. So really it's dire, and it's a very difficult situation. So therefore, to do a study that looked at hope and possibilities with communities and what they wanted, I felt was a good start to do this. But thank you for that question.
Person up there in the purple jumper, I think, next.
Thank you very much. Again, a very interesting set of talks. I really wanted to ask Harry, if I might call you that. You looked at the young who were dependent, who started early. Did you look at their parents? Because the data suggesting that you become a smoker if your parents are smokers. And did you find, if you did look at them, did you find those were the ones who really became dependent?
No, we didn't look at the parents, but that would be a very interesting thing to look at. Because, yeah, as you say, these things, smoking behaviour tends to get passed down through generations. So it'd be interesting how having a smoking family affects the age at which someone starts. So that's a really good question.
There was one around here. And please remember to introduce yourself if you can.
Thank you. I'm Giovanna, a student from Global Health and Development UCL. So this is a question for Linda. So now we're shifting from protecting pregnant mothers from research to including them in research. So I'm wondering about the ethical considerations in introducing vaping and NRTs for smoking cessation in pregnant mothers. And when there's potentially a narrative that vaping is safe, even for pregnant mothers, how do we stop younger people from taking up vaping? Thank you.
Great question, and that's a very difficult issue. Before I answer that, let me just say something about the previous question as well, if that's helpful, around the parental smoking. So they've looked at that in ALSPAC, which of course is another really valuable data set, that relationship between the parents smoking and younger people smoking, including some markers of dependence. And there is very clearly a relationship. So I think in those studies where we've got parents as well as children, it's hugely valuable, isn't it, to look at those issues. But in relation to your question, which is a great question, that is so in my policy role, in my government role, that is exactly the difficult issue for us to address. So how do you communicate to one population about the relative risks of a behavior and not risk that message being diluted or misunderstood by a different population? So if we say to pregnant women who smoke, particularly those who are smoking during pregnancy, so nicotine dependent, actually you can have this vape, because even though vaping's not safe, we're pretty confident it's significantly less harmful than smoking, while at the same time saying to young people who don't smoke, you shouldn't vape. And that is the kind of seesaw that we're up against. But the argument that we use from the maternal health side is that smoking in pregnancy is so uniquely harmful that if we can promote something which we think is lower risk, we will do that. But in the messaging, it's really important that we consider those two things. And in fact, that applies to the general population as well. How do you send the message to any adult smoker that vaping's a better option while not saying the same thing to young people? So I don't have the answer to how you perfectly strike that balance, but it is a key factor.
Thanks very much, Linda. Does anyone else on the panel have any ideas on how to strike that balance?
I don't have a simple answer. I don't think there is one. But I think it's about making sure that policies and messaging is both informed by and communicates relative harms. So any policies that restrict vaping in any way need to still get the message across that it's a better option than smoking. Sorry, would you speak a bit closer to the mic? Sorry, I'll hold it closer. So for example, this might be putting a minimum age of sale on vaping while introducing a smoke-free generation policy for tobacco. So putting the tighter restrictions on smoking while still regulating vaping. So trying to get that message across to people. It's not an easy thing to do, and particularly with young people, they often don't care whether things are harmful. They do things they want to do regardless of harm. So risk messaging is something that is particularly difficult for young people. We've seen actually younger people tend to have poorer harm perceptions of e-cigarettes, and yet they're the most likely to vape. So yeah, it's not an easy thing to solve.
I think there's a question here. Sorry, right in the middle.
Thank you. Sorry, I'm not working in this area, but I have a question. Because when I came to London, I observed there's a lot of people smoke on the street, and they feel very enjoying, feel very happy, but without notice others. Even though on the street there are lots of children, and there's lots of glasses, like drinking glasses on the street. It's broken. So I'm very shocked. Like, I think there any culture factories, why this happens for a long time. And as people, like when we see something like that, smoking, passerby, what can we respond to? And what's the role of education, culture, and anything can play in this solve the problem? Because everyone know, I think it's a common sense, like smoking is not affected our health, but also affect others, but why people not care? So I just feel like confusion. What they have any, like what we can do? Yeah.
Do you want me? I can start. So I mean, maybe you have a perspective from the alcohol research as well. So these things are cultural and they are embedded, and you know the UK has had, in the 50s and 60s, 80% of men smoked in the UK. We had the highest rates of smoking in the world by far, and then we exported cigarettes to the rest of the world. Can you hear me okay? No, right. I'll use this one instead because I've still got a little pen. Is that all right? Better now? Yeah, hear me at the back? Great. So I think there are cultural factors, but they're driven by availability, and it's the same with alcohol. And we do have a culture still of drinking outside, glasses outside, and smoking outside in the fresh air. But I think the kind of lesson of how you change that is around change the environment. Because, you know, there are many countries where people have changed the environment around the behavior and made it not possible. In many cases, made it illegal. So I think that is the key shift, and that's what we've seen. If you look at the social norms around smoking, they have changed. You know, people repeatedly will now have no smoking in the home, no smoking in the car, etc. And I think there is so much more we could do on the alcohol front, which is actually quite far behind. But I think, you know, it's important that we don't assume that it's about just how we do things, and this is what the UK is like, because we can change it. And I think smoking is a good example of that. But do you want to add from your perspective?
Thank you very much. I hope everybody can hear me. Yes, great. Okay. Thank you for that question. Is it, you know, sort of, you know, with regards to drinking and different ways of drinking, you know, when you said that everybody should know that, people know things in different ways. And if you're drinking, if you're a very heavy drinker, then your awareness of your behavior and how it affects other people may not be known to the drinker. And if your friends and everybody else drinks like you, and then you are not so sensitive or aware of other people, then that seems to be the norm. That becomes a normality for you. So that's the same as smoking as well, if your others are smoking and how it affects other people. So it's not such a simple thing as, you know, people should know. And also, when we talked from the previous question about messaging, we don't have a talk about drinking and alcohol use and drug use in a way that what could be helpful, how could we make ourselves better, how could we help each other, because these these topics are so stigmatized, people find it hard to express in words. That's why I use interdisciplinary approaches, creative ways of understanding experiences. And a lot of work that I'm doing is co-created with people. People with experiences are the experts, and that's where it should start. And with alcohol research and other sort of behavior changes, not just the individual, there's so many different factors. It's a complex area that we're dealing, working with. And the messaging, I think it's, we have different disciplines, the arts and sciences, and information design, I think that comes from graphic design. Alcohol advertisers and smoking advertisers are extremely clever, very, very effective at doing what they do, but public health messaging is really quite dry. When you really look at it, when you compare the two, how impactful is it, and why is it impactful? Why does it emotionally affect you when you see this very slick and very, very glamorous and very evoking kind of the little short film about a way of an alcohol or a type of alcohol drink and so on. So we need to re-look at this whole thing. It's a reframing of it, how we do research, how we communicate with people. So sorry, that's a bit of a long-winded answer, but I wanted to kind of share a few ideas that I had. Thank you.
Great, thank you. And I'll just use Chair's privilege to follow up on something Linda said, actually. So you said, to do better on alcohol, and I think it'd be fair to say over the last 20, 30 years, we've probably had a lot more success with tobacco control policy than alcohol control policy, although Scotland has had more success than England. Do any of you have any reflections on, can we learn anything from the successes of tobacco control over the last 20 to 30 years, and how might we apply them to alcohol over the next 10, 20 years?
I think we see very clearly in the smoking data that smoking rates fall when there is policy action, and when that action stalls and there's sort of less movement on that, we see less movement in smoking rates. So it needs a sort of dedicated focus and commitment to bring down alcohol, to actually have that investment and political attention on alcohol, which I think is really what we've been lacking in recent years. So a clear alcohol strategy and commitment to do something on it, anything, would be helpful.
Yeah, just to add, it's a very contentious issue. So in Scotland, we have minimum unit pricing, but we had a really good cabinet paper and policy paper on action on alcohol advertising, which just died. And I could see the discussions in the background, the lobbying from the alcohol industry. The contrast with tobacco is we've gradually had cross-party consensus on this. See, this bill that's got royal assent today was a Tory bill. It was a Conservative bill. And parties across the House, in both houses, were very supportive. We're nowhere near that on alcohol. So it's a difficult battle. And it's also made more complicated, the point I was making about us exporting cigarettes to the world. We export whiskey and many other forms of alcohol to the world. So there's a direct economic interest. But from a public health perspective, I think it's just important not to give up. I don't know if anybody else wants to add.
No, thank you very much. It's and alcohol, absolutely, when it's in policy, there's a government support. Minimum pricing has already been shown to be very effective, and there's been a huge sort of battle regarding that to getting that in place in Scotland, which is still ongoing. And there's also lack of research funding. Such little funding is available for alcohol research, a tiny amount. When I talk about the harm happens in the global majority countries, we're talking about sort of UK kind of focus here, which has been presented here by others. But seeing, with alcohol, it's more complex because it's not just the drinker; it's their family, their friends, their community is affected in many, many complex ways, and also. Therefore, it has to be kind of a joined-up approach, taking on projects and research that consider those in a multifactorial way, not in a very siloed, one topic, one sequential. This is happening in a very simultaneous, this is like a framework and structure that is kind of unstable, but also it has potential for really positive change. It could be very transformative if we look at it from a very holistic way, and that's why we think about, you know, the different disciplines coming together. We have lots of really interesting answers, and I think we just haven't dug into them and sort of transformed them. So thank you very much. Thanks.
Thank you. I believe we've got an online question.
Yes, can you hear me?
Yes.
Yep. So this is a broader question about prevention. So is there a risk that prioritising prevention becomes deprioritising the sometimes more complex healthcare needs of disabled people? I don't know who wants to have a go at that one.
I'm not sure if that if it would have an impact in this instance, like because like especially when we talk about the age of sale restrictions, I don't think that would have any impact on older people. That would be negative. No. Does anyone else have a?
I think I would add that tobacco and alcohol use is a major driver of disability. So prevention can help to prevent people from becoming disabled, you know, who would then, yeah, I think it all comes back to prevention.
Okay, thank you. Said I'd come here, and then there was one over here, I think. And then
Hi, my name is Chris. I'm a student from the University of Southampton, and I have a question for you, Dr. Dhital. So you were mentioning about the fact that a lot of the alcohol consumption was homemade, and it could range from between 5 to 40%, you were saying. How do you think that lack of ethanol measurement and consistency influence the alcohol intake changes we see in the UK versus Nepal?
Thank you. So just to clarify your question, so the kind of the alcohol production practice in Nepal, how it influences, what was the second part of your question?
How does it influence kind of like the rates of hazardous drinking and dependent drinkers? Are people as aware of the amount of alcohol they're actually intaking, and does that reflect?
Sure. Yeah, it's sort of different things because the alcohol production in the homes and local communities is also an important source of income. So when it's produced, it's for consumption in the home as well as selling, and therefore people are, you know, there's different types of alcohol with the different, if it's fermented, there's a awareness that's some weaker type of drinking, so people will buy that for different reasons, and there's sort of the higher concentration is drunk by men in sort of like little huts and sheds called parties in Nepal. And so there's different purposes for the different types of alcohol that's produced. And some of it's used for very religious reasons. It's produced in a very kind of, with the pure and the filtration system that has been known for a long time. So it does vary. But yes, you know, a lot of the drinking that we're seeing is sort of cultural kind of, you know, nice thing to do. It's really men are, you know, a lot of men, and it is mainly, and also women too now, and drinking to get totally drunk, and it's lack of socioeconomic kind of reason, there's lack of opportunities in jobs, mental health is all connected. And, you know, and a lot of people say, if I had something to do in my life, if I had some, you know, opportunity, I wouldn't be drinking. And it's usually very remote rural communities in parts of Nepal where people are isolated, and that's where the problems are the worst. Not so much in Kathmandu, near Kathmandu, where I was doing my research. That was, you know, in a particular area that we were looking at. But yes, it's very complex. Therefore, we need to remove the stigma and start to explore and bring out the negative experiences people are having from drinking, not just the drinker, but their family, their friends and communities, and make it more, and not just sort of we're reading about it, but it's more visible. We're actually trying to develop compassion about it and what it means.
Thank you, and thank you to the panel as well.
Thank you. I've been waiting very patiently, thank you. And then a question online. Yeah.
Hello, hi, Cameron Abbasi from the BMJ. Thank you for your presentations. It's good to see some positive data. It was very encouraging. For me, it boils down to the commercial and political determinants of health, but that would be a whole nother series of presentations. I want to ask you about social media. I mean, we haven't spoken about that, and whether it's in Scotland or Nepal. the influence of social media on people's behaviour, for example, in promoting alcohol or tobacco, is very, very hard to tackle. And I wonder whether you might offer some thoughts as to how, as a public health community, we might fight back.
Okay, right. Very timely question, I think, but I'm going to go a bit broader than tobacco and alcohol. So the toolkit study may have looked at the role of social media, and no, okay. But just on that particularly, we know that user-generated content is a way to get around regulation, around banning advertising, whether it's alcohol products or vaping or smoking. So it is an issue, and the wide use of social media means that that's where a lot of young adults, younger people are getting, information, etc. But I think we are heading into a period of really interesting policy development on social media generally. And that's for a number of reasons, not just what's happening in Australia with the ban for young people, but also the legal challenges that the companies are facing, and the growing body of evidence that shows us the harms that is caused by the platforms, by the algorithms, and by basically, as you point out, commercial practices. So the commercial determinants of health of online use, I think, is a really interesting area. And the final point I make on that, of course, is around trustworthy information. So in relation to people seeking help for alcohol use, for tobacco, etc., or indeed any health issue, we have a problem with social media as a tool to provide the wrong information. And that is really health harming. So I think these things are connected, not always directly, but sometimes indirectly. Do you want to add to that?
I can add something just specific. You might have seen Kenneth's poster, but just to give him a shout out, I'm his supervisor, but he did a study looking at nicotine pouch advertising on Meta platforms, so Facebook and Instagram. And as background, we see that there's been a sharp rise in nicotine pouch use, specifically among young males. And what his study showed was that adverts, while only a few of them specifically restricted the adverts only to be shown to young men, essentially the algorithm disproportionately fed the ads to young men, essentially reinforcing that pattern of use in those people. And there's no way to opt out of seeing those sorts of ads. So, yeah, that's an issue. And a broader issue on social media with addictive behaviours like gambling, or there's also issues with loot boxes now, which are essentially in video games where you have gambling mechanics where there's no actual real-world reward. You just get an in-game sort of character. But there are lots of companies that are advertising on social media, but it's hard to, you can only easily regulate things that are flagged as adverts, but when you have influencers who might be getting paid to promote certain products, or even just trends of people using certain products and talking about it on social media, you can see these sharp rises in use of things, even when it's not through traditional advertising methods of advertising, and that's much harder to regulate, I think. So yeah.
Do you want one more brief question? We can have one more brief question online as long as we have a very quick response, if that's okay.
Just to add to that,
Okay.
Just to say, I think in public health we should be sort of engaging in social media, because it is, it's another form of addiction, isn't it? We are addicted to social media. Lots and lots of people are, and therefore, how can public health engage with that? What kind of interventions and information that we can design for that platform? I think that will be so. That's a very important area that we haven't really engaged with, because that's relating to engaging with other disciplines and communication and information design. So that's something that I think is really important in public health.
Great, thank you. And I think with that, we should bring this excellent session to a close. So all that remains is to once again thank all our speakers for their excellent presentations and contributions now, and also to you, our audience, for your excellent engagement and really interesting questions too. So thanks very much again.
And thank you, Jamie, for chairing. That was a really superb session. I mentioned earlier the Public Health Disrupted, our podcast. The first episode of Series 6 is about young people and alcohol use, and it is really a fascinating podcast. I'd warmly recommend it to you as it connects so strongly with some of the things that have been said in this session. It's now time for a tea break. We have 15 minutes in which to get tea, coffee, and we'd like you back in this room, please, at 10 to 3. Thank you very much.